Hello, I welcome you to a discussion on the topic Medical Practitioners' Approach to Religious Patients. In the first part of this module, we shall have a brief overview of how the doctor-patient relationship should be like from the point of view of Parsons' sick role and learn about the mutual cooperation that is needed between both the doctor and the patient. We shall learn about the difference in position of the two thanks to the presence or absence of medical expertise. We will in the second part discuss about the models which will tell us about how patients can have their say in some situations and how they are just not able to or are not allowed to take part in the decision making of their own treatment. It might also be surprising to know how much mistrust or patients' own judgments about the prescribed treatment can turn this normal relationship into a relationship based on negotiation. We will also see how different factors like education, gender, and economic and social status influence this relationship pattern. In the third part, our main focus would be to find out who plays the role in handling religious issues of the patients. The fourth section would highlight the different ways of coping with patients' religious concerns, while in the fifth, the link between religion and OCD that has affected a good percentage of the global population shall be highlighted. We will know that a religious patient with OCD or obsessive compulsive disorder can be very much troubled in his life, and the role of a doctor must be to find a solution to the problem and not engage in mere mockery of the concerned. Moving on, the sixth section of the module will be dealt with religion-based psychotherapy to effectively treat patients of all religions. Spiritual history of a patient is the focus of the seventh part of our discussion. Spiritual history is important because it shall help us know patients' overall situation, about their beliefs and practices, hopes and fears. The eighth part would be devoted to a discussion of dementia and Alzheimer patients, and in finding out how religious rites and rituals can comfort them. And the last, that is the ninth part of the discussion, will be focusing on the ethical concerns of a doctor towards all of his patients. Keeping this brief overview in mind, let us now proceed to the main discussion on our topic for today. Parsons' concept of the sick role provided some basic guidelines for understanding the doctor-patient interaction. Parsons explains that the relationship between a physician and his or her patient is one that is oriented toward the doctor, helping the patient to deal effectively with a health problem. The physician plays the dominant role because he or she is the one invested with medical knowledge and expertise, while the patient holds a subordinate position oriented towards accepting, rejecting or negotiating the recommendation for the treatment being offered. In the case of a medical emergency, however, the options of rejection or negotiation on the part of the patient may be quickly discarded as the patient's medical needs require prompt and decisive action from the doctor. So, to understand very precisely, Parsons' concept of the sick role details the obligations of the patients and physicians towards each other. Patients cooperate with doctors and doctors attempt to return patients to as normal a level of functioning as possible. When people visit doctors for a treatment and medical advice, doctors usually take some type of action to satisfy the patient's expectations. But it must be noted that the role of the physician in meeting the needs of the patients is quite broad, and that physicians should be attentive not only to a patient's complaints but also whatever factors cause the patient to come to him at a particular point of time. The distress may not be always be physical. Purely psychological needs can trigger a visit to the doctor as well. Thomas Sachs and Mark Hollander, both physicians, take the position that the seriousness of the patient's symptoms is the determining factor in the doctor-patient interaction. Depending on the severity of symptoms, they argue that physician-patient interaction falls into one of the three possible models: activity-passivity, guidance-cooperation, and mutual participation. First, the activity-passivity model applies when the patient is seriously ill or is being treated on an emergency basis in a state of relative helplessness because of a severe injury or lack of consciousness. Typically, the situation is desperate as the physician works in a state of high activity to stabilize the patient's condition. Decision making and power in the relationship are all on the side of the doctor as the patient is passive and contributes little or nothing to the interaction. Second, the guidance cooperation model arises most often when the patient has an acute, often infectious illness like flu or measles. The patient knows what is going on and can cooperate with the physician by following his or her guidance in the matter. But at the end of the day, the physician makes the decisions. The mutual participation model, that is the third and the remaining one, applies to the management of chronic illness in which the patient works with the doctor as a full participant in controlling the disease. Often the patient modifies his or her lifestyle by making adjustments in diet or giving up cigarettes and is responsible for taking medication according to a prescribed schedule and seeking periodic checkups. The patient with diabetes or heart disease would be in this category. What Swaz and Hollander accomplish is to show how the physician-patient relationship is affected by the severity of the patient's symptoms. Now let me come to David Hayes-Bautista. Hayes-Bautista focuses on the manner in which patients try to modify treatment prescribed by a physician. He finds that they either try to convince the physician that the treatment is not working, or they counter the treatment with action of their own, such as by deliberately reducing the amount of medication they are supposed to take, or sometimes even by increasing it. Physicians respond by pointing out their expertise that the patient's health can be threatened if the treatment is not followed, that the treatment is correct but progress may be slow, or simply appeal to the patient to comply. The relevance of the Hayes-Bautista Model for understanding doctor-patient relations is that he views the interaction as a process of negotiation rather than the physician simply giving orders and the patient following them in an automatic, unquestioning manner. The model is limited to those situations in which the patient is not satisfied with treatment and wants to persuade the doctor to change it. In non-emergency situations, patients do not necessarily act passively when interacting with their doctors in health matters. Patients ask questions, seek explanations, and make judgments about the appropriateness of the information and the treatment physicians provide. But the interaction that takes place appears to be strongly affected by social class differences. Lower class persons tend to be more passive in dealing with doctors as authority figures and show a decreased sense of personal control over health matters. People with middle and upper socioeconomic status, however, tend to be more consumer oriented and active participants in the physician-patient encounter. This circumstance suggests that it is a middle and upper class patients who most likely try to negotiate with doctors and involve themselves as partners in the decision making of their medical problem, while lower class persons stand as more or less passive recipients of professional health services. Klausner discusses 4 different ideological positions on who should address religious issues. The secular reductionist claims that mental health is entirely in the realm of scientific psychology, whereas the religious reductionist claims that mental health is entirely within the province of religious belief and practice. The dualist argues that there are both psychological and spiritual problems and that a single qualified therapist can deal with both. Alternativists claim that there is only one problem, which is primarily psychological, and that either a minister or a psychotherapist can deal with it. Finally, the specialist maintains that there are spiritual problems and psychological problems, and each area should be dealt with by a specialist in that domain. From our perspective, it is likely that no one ideological position is applicable to all patients in all clinical situations. In certain disorders such as schizophrenia, the secular reductionist claim may be truer because of the overwhelming biological component to the disorder. In other conditions such as existential depression or issues related to death or dying, religious or spiritual factors may predominate and require the expertise of the clergy. In most conditions, however, both spiritual and psychological issues are present that overlap and are difficult to separate, requiring the expertise of either a mental health professional with background and interest in spiritual needs or a religious professional with considerable training in psychology. Often one professional will need to consult with the other and together treat the patient as a team. Sometimes, however, situations will demand that the mental health professional address religious or spiritual issues because the patient will not see a religious professional, or a religious professional must address psychological issues because the patient refuses to see a mental health professional. In any case, it is our belief that most psychiatric and spiritual conditions involve a mixture of psychological and spiritual issues, both of which need addressing to allow for the total healing of the person. Spero provides therapists with 7 ways of managing counter-transference issues that arise in these situations. First, the therapist needs to develop an understanding of the patient's neurotic and non-neurotic needs for religion. Second, the therapist must identify neurotic forms of religious belief. For example, how religion is used as a defense mechanism for aggressive drives or as a front for excessive dependency needs that reflect underlying psychological conflict, and must separate these immature forms of belief from mature forms that are adaptive. Third, the therapist must perform a self-examination in order to identify his or her own neurotic needs for religion and immature beliefs that arise from those needs. Recognizing how these are similar to or different from the patient's needs and beliefs will help the therapist to avoid or at least be conscious of counter-transference reactions during therapy. Fourth, when the therapist experiences negative feelings towards the patient, he or she should try to recognize if over-concern or over-identification with the patient is the cause for such feelings. Fifth, similar religious backgrounds of therapist and patient should not be grounds for either more or less appreciation of the patient. Avoiding special treatment will help the therapist maintain the therapeutic neutrality and objectivity necessary for therapy to be successful. Sixth, the therapist must recognize the limits placed on therapeutic goals when religious commitments are similar between patient and therapist, because this may restrict the therapist's ability to see how such commitments are used as unhealthy defenses by the patients. And finally, the therapist should try to avoid providing the patient with his or her own religious insights into the patient's problems, since this may distract from a major goal of therapy, which is to identify how the patient's religious beliefs are involved in his or her neurotic conflict. This does not mean, however, that the therapist should avoid pointing out and reinforcing adaptive forms of religious coping that may facilitate emotional healing. Let me make an interesting point here. You see, a Muslim patient will seldom initiate contact with mental health professionals. The concerned relatives, however, will make that contact. A Muslim patient will try religious approaches to achieve mental health concurrently with the modern methods. This should not be resisted or discouraged. If a faith healer is involved, work with that faith healer. Muslims believe in the existence of the supernatural beings called the jinns, who are made of fire and have powers of metamorphosis into different shape and form. Possession by a jinn is a legitimate possibility in the Muslim belief system. Such belief should not be considered a manifestation of psychosis. Patients who adhere to the Muslim faith may require running water in which to wash, and so may prefer to be offered a shower. It is considered imperative for people who are Muslims to clean the genital area after going to the toilet, and this requires the provision of a jug and the wash basin or a bucket. The left and right hands in the Muslim faith have very specific purposes, and for some patients it is considered an insult if these purposes are ignored. A person's left hand is used to provide hygiene, the right hand for nourishment. This can have important implications for a nurse who is left-handed and feeds a patient with their left hand, or the giving of intravenous fluids if it means the patient cannot use their hand for the appropriate purpose. The mouth, hands and feet are cleansed 5 times a day prior to praying. The sanctity and privacy of the female Muslim patient is considered paramount, and she may require that she is completely covered from head to toe to shield her from the gaze of male visitors, patients, or male healthcare workers who may come into the clinical setting. You need to bear in mind that your patient may object to wearing hospital clothes, and you will need to negotiate suitable alternatives. Now coming to Hindu patients. Hindu patients may require running water in which to bathe. Hindu religious laws require that the genital region must be washed after using the toilet. So patients will need to know that there is a jug and wash basin within the toilet area, or will be made available if they are confined to their bed space. If you are caring for a Hindu patient, you need to make sure that this care is documented in their care plan and that it is carried out. Female Hindu patients may wish to ensure that they can keep their legs, breasts and upper arms covered at all times. They may prefer to wear their own clothing during medical procedures and may object to wearing hospital clothing. Some Hindu patients may wish to wash prior to praying. Sikh patients also may prefer to shower. The adult male Sikh patient will have long hair, a beard, and the required to wear a turban on his head. The hair of the female Sikh patient is held in a bun. The hair of the Sikh patient must never be cut, as the head is the most sacred part of the body. Devout Sikhs may never completely remove their underclothes. They are required to push their underclothes down, leaving them over one ankle, only removing them completely when clean underclothes are in position over the other leg. The Sikh patient may need to wash once or twice daily before praying. A number of cross-cultural studies seem to support the hypothesis of a strict link between religion and OCD or obsessive compulsive disorder. Early studies found that in Muslim culture in Saudi Arabia, the themes of obsessions were more often related to religious practices than were evident in British OCD patients from a mainly Christian culture. A study found out the preponderance of obsessions concerning dirt and contamination among Hindus with OCD and noted that Indian culture is preoccupied with matters of purity and cleanliness. In another study assessing OCD symptoms in 34 Israeli patients, symptoms linked to religious practices were found in 13 of 19 ultra-Orthodox Jewish subjects and in only one of the 15 non-ultra-Orthodox Jewish subjects. Studies carried out within a single country can also highlight how religion affects OCD phenomenology. For instance, two investigations conducted in Turkey reported opposite results. One study in Western Turkey did not find a prevalence of religious themes in obsessions despite the influence of Muslim culture. The other study carried out in Eastern Turkey found that religion was the second most common obsessive theme after dirt and contamination. In fact, it is possible that dirt and contamination obsessions also reflected religious concerns within this culture. So, if the cause is religious, then a patient must be healed properly and must not be treated as a neurotic patient. It could be that OCD is likely to be characterized by prominent religion-related symptoms like blasphemous obsessions and contrition compulsions when a person is raised in a highly religious community, regardless of the person's country, language and other cultural factors. This last hypothesis, which I said, is very appealing and deserves further study. Townsend and others reported that two groups of authors in 3 studies tested the effectiveness of religion-based psychotherapy in treating religious people with anxiety or depression. Evaluations of the studies revealed Muslims suffering from anxiety or depression and receiving Islam-based psychotherapy appeared to have an accelerated recovery. Patients with anxiety or depression were placed in intervention groups and were given religious psychotherapy in addition to traditional secular psychotherapy. The religious psychotherapy was supported by advice from the Quran and Hadith. In another study, Propst looked at the effectiveness of religious cognitive behavioral therapy in treating depression in Christian patients. The patients were evaluated in one of these, which I will mention now. A. Religion-based cognitive therapy with a religious therapist. B. Religion-based therapy with a non-religious therapist. C. Non-religious or standard cognitive therapy with a religious therapist. D. Standard cognitive therapy with a non-religious therapist. E. Pastoral counseling. Or F. No treatment. What Propst indicated is that religious patients who had cognitive behavioral therapy appeared to recover. Interest in the association between religious activities and health has grown considerably in the past decade. Recent polls indicate that the US population is highly religious. Most people believe in heaven and hell, in the healing power of prayer, and in the fact that faith can promote recovery from disease. In fact, the popular press frequently reports cases in which religious faith and practices are said to promote comfort and healing. A spiritual history typically is asked in the context of the social history. A spiritual history is a set of targeted questions that invite the patients to share his or her spiritual and religious beliefs and that guide the patient to delve into the meaning of life events. The questions are not meant as checklists but as guides to help the clinician create a caring environment that encourages the patient to share his or her beliefs, hopes, fears, and concerns. The spiritual history is the process of interviewing patients, asking them questions about their lives in order to come to a better understanding of their needs and resources. The history questions are usually asked in the context of a comprehensive examination by the clinician who is primarily responsible for providing direct care or referrals to specialists such as professional chaplains. In this context, Anandaraja and Haidt posited that tools for spiritual assessment should be incorporated into medical practice. They designated the hope questions as a tool for assessing the spiritual and religious aspects of patients. The hope questions provide a formal tool that may be used in this process. The hope concepts for discussions are as: H stands for sources of hope, strength, comfort, meaning, peace, love, and connection. O stands for the role of organized religion for the patients. P stands for personal spirituality and practices. And finally, E stands for effects on medical care and end of life decisions. Actually, what was asserted is that a patient's family, environment, and social, cultural, and psychological situation should be included in the medical care of the whole person. A spiritual history is an interview in which the patient is asked a broader set of questions about his or her life so the clinician and team members can better understand how a patient's spiritual needs and resources may complement or complicate the patient's overall care. These questions are usually part of a comprehensive examination by a clinician responsible for providing direct care or referrals to specialists, including professional chaplains. Nurses who give spiritual care are engaging the core of who they are. This level of interaction creates meanings and memories that are life and health giving for the nurse as well as the patient. Emlen and Halstead interviewed 19 patients, 12 surgical nurses, and 7 chaplains concerning their perceptions of providing spiritual care and found the nurses' perceptions of spiritual care, including praying, establishing a trusting relationship, listening to patients, referring to clergy. Hall and Lanik maintained that Christian nurses reported that being with the patient, touching the patient, and being supported in times of crisis were important spiritual care behaviors. Vandover and Bacon noted that spiritual care has many functions in nursing and recommended nurses identify the spiritual needs and concerns of patients and their families and respond to the assessment of each condition. When nurses are comfortable and skilled in dealing with spiritual patterns, they are able to display their expertise in giving spiritual care. Nurses are often sensitive to spiritual needs. According to Vandover and Bacon, nurses have the ability to uncover the emotions and meanings of people and to recognize the spiritual aspects to human experiences of health and well-being. When patients with dementia have a religious background that includes a heavy emphasis on rituals, then engaging the patients in such rituals or prayers may help to reduce agitation and increase cooperation. Repeating the 23rd Psalm or the Lord's Prayer with the patient may have the same effect. Again, however, a thorough religious history is necessary from the patient or from the family if the patient cannot remember or communicate. Several types of religious interventions may need to be tried, although finding out which religious behaviors, rituals, prayers, or hymns were particularly meaningful to the patient will probably be most successful. If the patient has never been particularly religious, however, such interventions are unlikely to help. Religion can also assist patients cope with the stress involved in the development of dementia, especially the early stages when patients still have insight into what is happening to them. This is a time when emotional distress like depression or anxiety is common. If religion has been of value to patients in the past, then it may be used to help calm them as they recognize that they are losing control. Praying with patients, reading religious scriptures to them, or singing favorite religious hymns may all serve to calm their emotions, just as for patients with more advanced dementia with agitation. Both cultural and religious diversity is rapidly increasing. For example, the Islamic and Jewish populations in the US, when combined, are now larger than many Christian denominations. Engaging in religious discussions or praying with patients, therefore, becomes an increasingly complex issue. Many patients, no doubt, try to select their physician on the basis of a mutually held cultural and religious background, which makes such religious discussions easier. But this freedom of choice is declining rapidly as managed care programs dominate the market. As many authors point out, there is no problem with co-worshippers discussing medical issues in the context of a shared faith, but the increasing religious diversity dictates the importance of proper knowledge and preparation. The obvious solution to this concern is the referral of patients to the appropriate trained clergy or chaplain. Also, life experience for each of us is of one piece. Down deep, everything is connected to everything else and life has an internal coherence. The scientific mentality has strengthened our ability to pull life experiences apart, to break them into pieces for study. Anxious patients sitting in the doctor's exam room or lying in a hospital bed, however, are usually not very scientifically minded about their situation. Their existential experience of the moment is a unity, and all aspects, including religious and spiritual ones, are at least implied during visits with their physician. No rule is going to screen such concerns out of that professional relationship, and sometimes these issues will surface for discussion. It is a different matter, however, when physicians encourage, cultivate, or overtly raise religious issues with patients. Such behavior by physicians raises a host of relevant issues for parish clergy and professional chaplaincy. Are physicians trained to facilitate such discussions? To answer with a yes to this question implies that current medical training, the physician's own religiousness or general interest in this area constitute sufficient credentials. This demeans the importance that religion holds for many patients and simply dismisses all the energy and struggle that clergy have invested in their theological training and clinical pastoral education. It should be worrisome to clergy if self-declared expertise is all that is needed on the part of interested physicians or other healthcare professionals. Such a stance moves uncomfortably parallel to the problems of self-ordination and the private practice of ministry that established religious faith groups have always opposed. They have opposed it because, as the medical profession itself knows, without the academic and clinical preparation as well as supervision of professional peers, such individuals usually give in to the temptation to manipulate vulnerable patients for their own advantage. Additionally, physicians will discover that deliberately involving patients in religious and spiritual discussions will rapidly escalate into complex personal and theological dilemmas for which they are not trained. Thus, attention to these concerns cannot simply be absorbed into medical practice as if it were a new procedure that only requires a weekend continuing education course. The healthcare professionals must not allow physicians to simply declare themselves as competent to engage patients around these important religious concerns because they happen to be interested in them. If they wish to incorporate attention to religion, then they must, by their own code of ethics, obtain sufficient training and incorporate this content into their certification examinations. Such training and testing are highly unlikely, and they imply that for the most part physician-initiated attention to the religious concerns of patients will verge on the edge of being unprofessional, as these authors observe. Finally, clergy must speak out whenever religion or spirituality is appropriated for utilitarian reasons, in this case for their potential health benefits. Such attempts are degrading to religious faith and practice, whose driving force can never be intentional self-enhancement. As a conclusion to this module, all that can be said is trust and cooperation need to be the main binding force of a doctor and patient's relationship, where both of them must realize the need for mutual participation whenever situation permits. Sex, education, class and religion must not be the factors of inhibiting such discussion. Who should play the role in healing a religiously oriented patient must be understood well before it is too late to expect any outcome. A patient's religion and the related religious practices can be different from that of a doctor, but that must not be a reason to treat the patient with disrespect. Cognitive behavioral therapy, performance of religious rites, ritual and praying with patients, if thought by both the patient and doctor in bringing about positive results, then there can be a provision to include them in treating patients, but of course, keeping the various ethical concerns in mind. Knowing a patient's spiritual history through the patient's religious heads can help doctors know about the entire religious history, which can help to heal diseases. In this way, many serious diseases which results in hopelessness, anxiety and irritation can be moderated by religious observations. Thank you.